Now, when you think about the treatment paradigm of multiple myeloma, the obviously, as we already talked about, the two important components, the accurate diagnosis and then assessing the risk of the underlying myeloma. Then the initial treatment of myeloma is probably the most important, as this often allows patients to get into a deep response that can sometimes last for years. Unfortunately, the majority of the patients with myeloma today will relapse after that initial therapy, and then we will go through multiple different lines of treatment over time. So we're going to focus primarily on the treatment of newly diagnosed myeloma, the initial treatment that the patients receive. Now, the type of therapy is often dependent on whether the patient can undergo an autologous stem cell transplant or not. And the eligibility for autologous stem cell transplant can vary quite a bit depending on the age, the presence of other illnesses or comorbidities that might make the transplant related side effects intolerable, and of course, patient preference. Now, in patients who are considered eligible for autologous stem cell transplant, for a long time we have been using a combination of bortezomib uh, that belongs to a class of drugs called proteasome inhibitors, lenalidomide, which is an immunomodulatory drug, and dexamethasone or steroids. We know by using these three drugs, the outcomes or the survival of the patients can be much better than just using two drugs like the lenalidomide and dexamethasone. Now, what has happened more recently is that we have a new class of medications called monoclonal antibodies. Daratumumab was the first one, isatuximab was the second one, then there's another one called ilotuzumab. Now, these monoclonal antibodies tend to be targeted therapies that where the monoclonal antibody goes and binds themselves to the tumor cells or the plasma cells that then can lead to their death. Now, with the advent of these monoclonal antibodies, a large phase 3 trial was done trying to see if we can improve the outcomes of that three drug combination, the VRD combination, by adding the daratumumab on top of it. So patients with newly diagnosed myeloma before they went to transplant received treatment with either the three drugs or the four drugs, had a transplant, got some additional treatment with the three or four drug combination, and then continued on a maintenance strategy with either one or two drugs. And the trial showed that by adding the monoclonal antibodies, you can get patients into a deeper response, and more patients are able to get deep responses. And this benefit was seen across the board, irrespective of the underlying types of myeloma or myeloma characteristics, including risk. And when you look at the progression-free survival, at 4 months after the start of therapy, nearly two-thirds of the patients had the myeloma under control with the three drug, and nearly 20% more people were able to have their disease under control by using the four drug, suggesting that the four drug based approach is much better. And when you look at the various subgroups of patients, depending on the disease characteristics like the high risk or the age or the gender, the benefits seem to be similar across the board. And when you look at the overall survival, you can see that at about 5 years from diagnosis, nearly 90% of these individuals are alive, which is significantly better than what we used to see in the past before the advent of these new drugs. Now, once the patients get 4 to 6 cycles of that induction therapy, we offer the patients the possibility of going to an autologous stem cell transplant. The autologous stem cell transplant includes high doses of chemotherapy and collecting the stem cells ahead of time before chemotherapy and reinfusing them after the chemotherapy allows the patient's bone marrow to come back to the normal shape, but with at the same time having gotten rid of most of the myeloma cells. Now, there are multiple phase 3 trials that have been done that have shown that using an autologous stem cell transplant versus not using a transplant is associated with better survival. Now, more recently, the trials have been done where they have looked at the concept of doing a transplant early on, so within the first 6 to 8 months of diagnosis, versus using the transplant at the time of relapse after that initial treatment. And what we have seen in these trials is that the progression-free survival is much better, meaning the disease is controlled in a more effective fashion for a longer period of time if you use the transplant upfront. But we also know that if you delay the stem cell transplant, to the time when the myeloma comes back after that initial treatment, you can still get the same overall survival, suggesting that patients can opt to have a transplant either in the beginning or at the time when the myeloma starts coming back the first time. The same approach was taken in a different trial done in the US called the determination trial. Like here again, patients were randomized to getting 3 drugs or 4 drugs. Then they underwent stem cell transplant, and in one group, and in the other group they just continued with the same treatment. Again, very similar. We found that the disease stayed under control for a longer period of time if we used the transplant early on. But as long as you use the transplant early or late, your overall survival remained same, suggesting that patients have the option to get a transplant later on as well. However, this trial also showed that significant benefit, a much more profound benefit was seen among patients with high-risk disease. As a result, we typically try to take patients with high-risk myeloma to a transplant early rather than delay that for the time of disease relapse. The question that comes up is after you have the autologous stem cell transplant and the disease has come under control, what else can you do to keep or the disease under control for longer periods of time? One approach is to put patients on maintenance therapy, which is low dose of medication given for a long period of time, or giving patients additional treatment before going to the maintenance, or giving them a second transplant called a tandem auto transplant, and then going to maintenance treatment. This trial showed that it doesn't matter. All 3 approaches seems to have quite similar results. So why give additional therapy? Instead, let us just do maintenance itself. And that is what we have been doing in our own practice, is to try and just give patients a single drug maintenance after the transplant. Now, we know that about a quarter to third of the patients with high-risk myeloma don't do as well. And in those patients, what we have seen is maintenance with just one drug may be insufficient, and we may have to do more than one drug. Now, there are multiple trials that have been done looking at using the lenalidomide or the Revlimid maintenance after autologous stem cell transplant, and this is associated with improved survival, and patients live almost 2 years long. More recently, we have used that anti-CD38 monoclonal antibody called the daratumumab, and when you use daratumumab as maintenance, you still see an improvement in the duration for which the disease is controlled. Now, as I said before, if you have high-risk disease, one drug may not be sufficient to maintain the response. And in those situations, we use 2 drugs, like what was done in this particular trial, where a proteasome inhibitor similar to bortezomib called carfilzomib was combined with the lenalidomide or Revlimid and compared to Revlimid alone. And this trial showed that 2 drug is probably better than one drug maintenance, particularly in those patients with high-risk disease.